अरे कैमरा दिख रहा है? कैमरा दिख रहा है? मैं फुल स्क्रीन जा रहा हूँ। कैमरा दिख रहा है? Okay. Okay guys, now Eric is showing me that the camera is working fine. Hello guys, welcome to Health, Music and Fitness channel, and thank you for joining again. And as you can see, there must be some improvement in the quality of the camera. And please type in the comments box if the lighting is okay and the camera is looking better than in the previous streams. Because previously I was using the laptop camera which had a very poor resolution, and I was almost going to invest in a very good webcam for around 15,000 rupees, 12,000 rupees. And then suddenly I saw this small YouTube video how to use your phone as your webcam. And this camera is streaming through Note 9, and I am reading the slides on the laptop, and it's giving excellent quality. So thank you all for joining, and we'll start. Sorry for the little delay in the start. So we are into the fifth lecture of ECG made easy, or basics of ECG. And for all of you who don't know me, I am Dr. Robert James, and I did my MBBS and MD medicine from Christian Medical College, and I am also a fellow in clinical cardiology and echocardiography. And we have till now discussed a lot of things. We have discussed about what an ECG paper is, what is calibration, what is axis, what are the different leads. There are V1 to V6 anterior 6 chest leads, and there are standard limb leads and augmented limb leads. Lead 1, lead 2, lead 3, AVR, AVL, AVF, then V1 to V6. And we also discussed that right ventricular infarction, for that you will record leads on the right side, V3R, V4R, and if there is ST elevation of more than 1 in one small square in V4R, it is a very grave prognostic sign, and it signifies poor outcome. And in such patients, they will have a very poor compliance, and you should not load them with vasopressors, because then the heart can fail. And restrict the fluids. Vasodilators you avoid, like beta blockers, nitrates. Even nitrates will worsen the condition if there is a right ventricular infarction. If the BP is okay, BP is more than 110/80, you can give nitrates. Otherwise you avoid nitrates, especially in inferior wall MI, where you will also have usually right ventricular infarction and associated posterior wall infarction also. And I also told you that whenever there is lateral wall MI, which is part of anterior wall, and you will see a right axis deviation, because this part of the myocardium is bad, it has necrosed, infarction has taken place. So this part's electrical activity has decreased. So lead 1 we are plotting at 0 degree. So we will plot now at 180 degree. I told you if 1 becomes less positive, plot it at negative end. Automatically you think that AVF has become more positive. Lateral leads and inferior leads, they oppose each other. V1 and V2, they will oppose V5, V6. Okay, and this funda works, and this funda only I have put in this circle. Okay, you see this circle. So if 1 becomes negative, this is a positive polar lead 1. We'll plot it here. And then AVF, you make it positive, positive, positive. So right axis deviation. So if there is an inferior wall MI, 1 becomes negative, AVF becomes positive, 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 and right axis deviation. Similarly, inferior wall MI, this part of the myocardium has necrosed. So AVF is negative, negative, negative. Make lead 1 positive, 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 LAD. Okay. And then we also discussed about conduction blocks. We discussed about LBB, RBB, LAHB, LPFB, and bifascicular blocks. Bifascicular blocks basically means LAHB with first degree AV block, or RBB with LAHB, or RBB with LPFB, like that. So right bundle branch and left bundle branch, they cannot be blocked together. Otherwise, then you will have a complete heart block sort of situation, and patient will need piercing, and it will be a life-threatening situation. And most of the times, I also told you, left-sided heart blocks and left-sided blocks, left-sided conditions, they are more serious, because left ventricle is pumping the blood into the whole of the body. Okay, so that is very serious condition, a fresh LBB, a fresh LAHB. So, and we also discussed about increased ventricular activation time, VAT, increased ventricular activation time. Basically, we discussed about intrinsicoid deflection, and I will show you intrinsicoid deflection. One sec, guys. So intrinsicoid deflection, I told you, like when the Q wave is forming, from there is a R wave starting. Okay, just a sec, I will show you. Okay, so this is the intrinsicoid deflection. So in this you can see, sorry, so this is the intrinsicoid deflection, and can you guys see the PowerPoint? Today I'm not able to see what you guys are seeing because the phone is being used for the camera. Eric, aa raha hai isme? There's a lot of buffering, so just show me. So Priya, Raghav, Rebecca, welcome. Thank you for joining. Yukanish, welcome to the stream. So guys, okay, I just want to see if you can see the PowerPoint. There's a lot of delay and buffering is happening. This is supposed to be a very high speed connection, but there's so much of buffering and it kills the fun. There are more than 3 or 4 minutes of delay. I'm still talking in the browser. So till I can make sure that you guys can see the PowerPoint till the buffer is over, I invested in 2 small lights, headlamp, and one lamp is behind me, which is creating a halo. These things I learned from YouTube creators, and thanks to all the YouTube creators, and you people are so helpful, and you make our day. Like I was struggling with good resolution, how to get a good resolution without spending too much of money. So I just had to buy 2 lamps, and that changed the whole thing. Okay guys, I'll just yes, I think you will be able to see the slides. I'll proceed with this thing lecture. So this is the intrinsicoid deflection, and this intrinsicoid deflection starts from the R wave. If there is a Q wave, we will start from the Q wave. If there is no Q wave in the complex, in the ECG recording, you will start from the beginning of the R wave till the tip of the R wave. So that makes it so I was talking about the intrinsicoid deflection. So till the tip of the R wave. So this delay, it should not be more than 45 milliseconds. Okay, and see, this is the intrinsicoid deflection from here till the tip of the R wave. So usually the R wave has to be like this. If it is like this and coming down like this, that is increased ventricular activation time. Intrinsicoid deflection is delayed. So that can signify that this person is going to form a LBB or a LAHB after a few days, months, or weeks, and you have to be very guarded because that is definitely not a good thing, and it signifies sclerodegenerative disease of the conducting system somehow. And so that is the intrinsicoid deflection. So we'll come to the lecture of today's lecture. and this all we have discussed already. So I will revise little bit about myocardial infarction, and in fact our lecture about MI will be over very fast today. Oops. So okay guys, so let's start, and you have to bear with the buffering because I'm really disappointed with the net speed. This is supposed to be a 50 Mbps connection, and this is such a bad speed. So today's topic is again myocardial diseases, coronary artery disease, and I will just rush you through these few slides which we discussed last time. We will not spend too much of time, and after that there will be a few slides on atrial MI and Garbos's criteria. These are very important things, and pseudo normalization of T waves. So coronary artery disease, ischemic heart disease, in this you will have poor blood supply to the myocardium. So when the heart rate increases in response to stress, or when the body's oxygen requirement is increased, like in stress you have to run or something, your muscles need more blood, and then the heart will pump more. There will be adrenaline release, cortisol level release. Cortisol is a stress hormone, and it will cause tachycardia. And in that case, your cardiac muscles also need more oxygen because they're beating at a faster rate. But that is not happening because there is a clot or a plaque inside the coronaries, or because of stress there is a coronary spasm, and because of that there will be ischemia. Okay, and I told you in the last lecture, there can be upsloping ischemia, and there can be horizontal ST depression and a downsloping ST depression. So this is what the upsloping ST depression will look like. Like there will be R wave, and the ST is depressed, but it is moving up only, okay, towards the isoelectric line. Then there is a horizontal, so P wave, QR, and the ST doesn't reach the isoelectric line. Okay, it is horizontally progressing, then it makes a T wave. Then there is downsloping ST depression. So in the third slide out here, so you are seeing the ST depression which is downsloping. Okay, and these are very important, 3 ischemias, and so we graded mild, moderate, severe. And so next we discussed, okay, so this is some authorities say if your ischemia is more than 2 small squares of depression and 2 small squares of width, so that is a significant ischemia. Some authorities say there have to be 3 small squares, so like that. Okay, and I also told you T follows R. If there is a good R wave and the T is becoming flat or inverted, that could be a subtle sign of ischemia. And these ischemic changes, they will become even more prominent when we exercise. Now in this slide you see, this is a heart rate, this is an ECG rhythm at a heart rate of 59 beats per minute. Okay, and ST is looking normal only. Okay, it is at the isoelectric level. So all the complexes, P wave, QRS, T wave, they are starting from the isoelectric complex, isoelectric line, and they are ending at the isoelectric line. Now in this same lead, same patient, heart rate of 85, you see ST has started depressing. Okay, so this could be a significant sign, and signifies severe coronary artery disease, because you should have a capacity of running, and your heart should be able to take the load. Roughly you have to, the rough formula is 220 minus your age. So this much of heart rate you should be able to sustain for at least 15-20 minutes. Okay, and 220 minus age is like at least 120 or 130 beats per minute. For you people, you guys are young, so it will go even more, because 220 minus less of your age, so it will be even more. So that much amount your heart has to be able to tolerate, and without ischemia. And sometimes we call this rate dependent changes. Supposing this 59 heart rate was, let us say, 100, and then we did this second ECG, and let's say in second ECG the heart rate is around 140, just presume it is 140, then ST might be looking little depressed. In that case you should not comment definitely over the ischemia. You can just say, sir, there is rate dependent STT change, and once the heart rate has become normal, then we will re-evaluate or subject this patient to a treadmill. Okay, again I told you, before you do the treadmill you have to do an echo. Okay, so you do an echo, one sec. Okay, so you do an echocardiogram, because we have to rule out dilated cardiomyopathy and hypertrophic cardiomyopathy, hypertrophic subaortic stenosis, all the serious diseases. How come? So you have to rule out these things, and if you make these patients run, and they can suddenly have a cardiac arrest or ventricular tachycardia, because already their heart is irritable. A stressed myocardium is an irritable myocardium. A dilated cardiomyopathy heart is a irritable myocardium. So if you subject these patients to stress, they can develop arrhythmias very easily, because in dilated cardiomyopathy the ejection fraction is very low. Our normal ejection fraction is from 50 to 70, and less than 50 is pathological, and more than 70 is also pathological. If it is more than 70% of ejection fraction, then it could be meaning that the patient has severe HOCM. The myocardium is very, very hypertrophic, so it is pumping even more effectively. But that effectiveness means it comes at a price. Then your heart needs more oxygen for those hypertrophic muscles. Now in this you will see this is a horizontal ST depression. Okay, out here it looks like a downsloping. It's going almost down. This is down. Okay, so this is down. In this it is horizontal. So now you will say, sir, this is horizontal, this is downsloping. How can it be in the same person? Now see, this is lead 1, that is horizontal. Okay, lead 1 is lateral lead. So maybe LCX is supplying or LED is supplying lead 1 area, and lead 2 right coronary, probably the right coronary is supplying the lead 2 area. So maybe this person has a triple vessel disease. So that is how you have to play with your findings, and you have to play with your thoughts. Keep on asking yourself, can it be this, can it be that? And then while you're looking at the MI, you look at the P wave also. Today we will be discussing about atrial MIs also, because it's very important. Most of the times we don't even think of atrial MI, and we just say Tropt is positive. No, this is not MI, this is probably a wrong report. But you look at the P wave amplitudes and the distal limb of the PTA segment, we'll come to that, and you might see a MI in the atrium, atrial MI. And many of the times atrial MI, they will present with atrial fibrillation, atrial flutter, and other atrial rhythms, atrial ectopics, and once those things settle down, you might see a atrial MI. We'll come to the slide soon. Now you see this is a downsloping ST depression. So ST is depressing down. Okay, it's not rising up, downsloping. Okay, then what else does this ECG have? So let's not miss other findings. So always look at the ECG like this at least 2-3 times. Now in this ECG, what do you see? Last time I had told you I am seeing this ECG again because there are so many ECGs. I have a big solid collection of ECGs. Wherever I get interesting ECGs, I click pictures. So you see in this ECG R wave amplitude. Okay, it is varying. Yes, last time we discussed the R wave amplitude is different in all the leads. So this means this is electrical alterance, just like pulses, paradoxes. This is electrical alterance, and this signifies a myocardial disease. Maybe this patient has also pericardial effusion. Maybe the myocardium is so damaged and irritable, it is contracting in a different sort of way. Different areas of myocardium are dyskinetic, akinetic, hypokinetic. So you might get this type of complexes. Now you see in this ECG, so there are a lot of ectopics in this ECG. Okay, so you see this is P wave, R wave. Now if I say find the axis, this ECG I know we had discussed last time, it was difficult to comment on the axis, but this is an isoelectric complex, and this is also sort of an isoelectric complex. I know R is taller than deep than S wave, but there is a R wave and a S wave, and R wave is positive, more positive. Okay, So the axis is again at around 0 degree. So lead 1 has become positive, AVF becomes negative, minus 90 degree we plot AVF. So it is left axis deviation quadrant. Okay, so like that you have to determine. Then you look at the duration of the QRS complex. Once you have determined the zone, is it the LAD zone or a normal zone, normal axis area, or a RAD axis area quadrant, or a extreme RAD or extreme LAD zone. Okay, so now we have determined this is a LAD. See in AVF. Actually, it's difficult. Last time also I got stuck on this ECG, and let us say this is positive. This in out here there are a lot of ectopics, but this is isoelectric. This is lead 2. Okay, this is isoelectric. So what is perpendicular to lead 2 in the LAD area? Minus 30 degree. Lead 1 is at minus 30 degree. Okay, so sometimes it will be difficult. There can be indeterminate axis, and in that case you will see isoelectric complexes in lead 1, 2, 3, AVR, AVL, AVF, and in that case you cannot comment on the axis. You just say so the axis is indeterminate. Even the good ECG machine, it will give you an interpretation after the ECG recording. There also it will be written axis indeterminate. Now this is a very nice ECG of one of our patients. Just look at this, spend some time on this ECG, just see. And I have taken different ECGs at different times, okay, same day after few hour intervals. So this was the first ECG taken, then second ECG, then third ECG, then fourth ECG. Okay. Divya, Lokwani, Ranjana, good evening, welcome to the stream. I have to borrow Eric's tab again and again to see the comments. So guys, you see in this ECG, there's a lot of buffering. His laptop is, his tab is still showing ischemic changes, upsloping, downsloping. So anyway, you can see this video again and there will be no buffering at that time. Okay guys. So in this ECG, what you see is you study all the complexes. Is there any loss of R wave progression? So see, V1 you see, lead 1 you see, R wave is good, okay. Lead 2 R wave is good, and lead 3 there is a R wave, okay. So probably other leads will be okay only, AVF, R wave is there, okay. Now you see in V1, V2, V3, V4, there is no R wave progression seen. So this is called loss of R wave progression. And some people will confuse it with Q waves, but these are not Q waves, okay. These are R waves. R wave, then there is a deep S wave. So this is loss of R wave progression. Slightest upslur on the QRS complex, although it may be looking at as a Q wave, it is called small R wave and the QRS complex, okay. So but sometimes in some places you will feel it is a Q wave. See out here, this is a RS complex, okay. This is loss of R wave amplitude, and that shows myocardial ischemia, and this patient probably had recent anterior wall MI. Then you look at other things, you look at the P wave in V1. So whenever you have to study or comment on P wave, you see in lead 2, because the current is coming straight from SA node towards lead 2, you will get a good size P wave, good size QRS complex, good size T wave, okay. So in V1 you see P wave is biphasic. There is a very small positive wave in the P, and that is because of right atrium. Then there is a negative component of the P wave, that is because of left atrium. So but the negative component is very prominent, so that is showing that patient has a left atrium is dilated. Probably this patient had anterior wall MI, and after that also had is having left atrial enlargement. So we have seen this circle again and again, and you have to memorize it, by heart it in your mind, and when you're looking at the ECG rhythm like this, you should be able to plot all the changes on this circle. So SA has fired, goes to LA, RA, and for AVR it is always going away towards lead 2. So all complexes are inverted in AVR, and lead 2 is getting all the positive complexes like this. Electrical activity is towards the lead 2. So P is good size positive, QRS is good size positive, T wave is following the R wave. Okay, this funda you have to be very clear in your mind, and then ECG is very much fun. Then look at the intraventricular septum. From left towards right side, it is getting depolarized by the left ventral branch, or this one or this one. Okay, so when it is depolarizing like this, for V1, V2, impulses are coming towards V1, V2, and V1, V2, they draw a small R wave. Okay, because intraventricular septum is very thin. Okay, and R wave, V1, V2 draw R wave, small R wave. During that time, the rest of the lateral leads, they are drawing a small Q wave. Okay, then a deep S wave is drawn when the impulse goes away from V1, V2 to depolarize the left ventricle. So V1, V2, they draw a deep S wave, and reciprocal of that will be drawn a positive R wave in V5, V6. So I said V1, V2, they oppose V5, V6. Something small happening in, small positive happening in V1, small negative happening in V5, like that, or V6. Deep S forming in V1, tall R forming in V5, V6. So this funda you have to be very clear. Something positive happening in lead V1 and negative happening in lead AVF. Okay, so it's like a dance movement. You have to memorize it, and it's nothing to memorize, just you have to know it. You won't forget it again. So transition zones we discussed, and if this patient develops, this is a normal transition zone. The R wave becomes taller than the S wave between V3, V4. Okay, so supposing this patient develops a left ventricular MI, lateral wall MI, apical MI. Okay, so then the amplitude of these dominating left ventricular forces will decrease, V5, V6. So the counterclockwise little bit of power V1, V2 and these leads will get, because V5, V6 have become less positive because there is an infarction. So in transition zone occurs between V3, V4. Now there is a MI in the lateral wall. V1, V2 become very happy that they have become now very strong, because the lateral leads V5, V6, lead 1 AVL, they have become less strong. So they will make a R wave, positive good R wave, very faster than before reaching the transition zone. So there will be a counterclockwise rotation, counterclockwise electrical rotation of the heart. I hope you got it. You can revise, you can repeat the slides again later on, because right now buffering is too much, and if you still don't understand, you're most welcome to message me or leave a comment in the comments box, live chat or offline live chat comments, and I'll be very happy to clarify the doubts. Now this is a very important slide, and you see there is left coronary and right coronary. Okay, left coronary divides into left circumflex and left anterior descending. So then there are D1, D2 branches, okay, and OM1, OM2, and these LAD and all these coronaries, they supply different areas of the heart. Now you can remember left anterior descending, left side, anterior. Okay, so LAD supplies L for left, A for anterior. Okay, so I have remembered it like this. I always make mnemonics in my heart and it stays. So anterior part of the left ventricle, anterior part of the heart, anterior lateral walls, and the anterior 2/3. So mind you, I have highlighted all this: anterior, anterior, anterior. So anterior part, anterior lateral part, anterior 2/3 of the interventricular septum. Posterior 1/3 of the interventricular septum is supplied by right coronary. Okay. So LCX supplies the posterior lateral wall of the left ventricle. This is LCX. So this is the anterior lateral, posterior lateral, anterior lateral, posterior lateral. This is the heart. Okay, so you have to mirror image my actions, then you will be able to understand, because I am looking at the heart from my eye side. Okay, so from your side it is inversion. Then the right coronary, it supplies the right ventricle, inferior diaphragmatic surface, and the true posterior wall of the left ventricle, and the posterior 1/3 of the interventricular septum. Now when we say posterior wall MI, we are talking about true posterior wall of the left ventricle. Okay, and right coronary, it supplies around 85 to 90% of the times to the AV node. So now you see AV node is supplied around 90% of the times by right coronary, And we have always discussed inferior wall MIs, they will usually present with bradycardias, bradyarrhythmias, blocks, complete heart blocks, secondary complex blocks, and left lateral wall MIs and anterior wall MIs, they will come with usually have tachycardia, tachyarrhythmia, because the AV node is knocked out by the MI because the right coronary is blocked. Okay, so AV node malfunctions. These we have already discussed: V1 to V6 anterior wall, V1 to V3 anterior septal, V3 V4 septal, and V5 V6 apical, lead 1 AVL, V5 V6 lateral, lead 1 AVL high lateral, lead 1 AVL V1 to V6 extensive anterior wall MI, 2-3 AVF inferior wall MI, V3R V4 ST elevation plus V1 V2 RVMI, right ventricular infarction, mirror images in V1 V2 posterior wall MI. To see posterior wall MI, you can also take leads posteriorly on the left side, V7 V8 V7 V8 V9 V10. Okay, so we have discussed all this, and we also discussed that anything positive in AVR signifies a serious disease. Now you see, I will flip through the slides fast. So what's the time? Okay, we have some time, guys, so we'll finish on time, 1 hour only. So AVR shows ST elevation. Now something is sinister, something is bad in this ECG. There's depression out here, and there's depression, upsloping depression out here in inferior leads. In the anterior